Welcome to the Clinical Appraisal Podcast. My name is Ian Lane, and on this show, we discuss the science and theory of nursing. I'm a critical care nurse and PhD student in nursing science focused on measurement and methodology. Importantly, nothing I say constitutes nursing advice. This is education only. And if you want to get in touch with me, please email me at clinicalappraisal@gmail.com. If you want to donate to the show, links are in the description, and otherwise, like, comment, subscribe, and share the show if you enjoyed this episode. Today we are going to talk about nursing theory. I have a paper from 1963 entitled Nursing, What Is It? By Lydia Hall. Lydia Hall was a nurse in New York State and was the director of the Loeb Center for Nursing and Rehabilitation at that time. This paper was presented in 1963 at a Toronto conference and is considered one of the classic papers in nursing meta-theory. I don't believe that Lydia actually considered her ideas in this paper to be meta-theoretic or to presuppose some grand narrative about what constitutes nursing per se, but I think just by virtue of the question, what is nursing, because it's a grand question, people took this paper as sort of an explication or exploitation of a grand narrative of what constitutes nursing at the fundament. So there are innumerable ways to read papers like this, and there are a host of interpretations of papers like this that I may not have thought of, and leave a comment in the comment section if there is something that I did not say about this that you would like to point out if you've read this paper or if you're reading along with me. But what I'd like to do is essentially talk about what things stand out to me and what I find to be compelling or important about Lydia's work. Why am I doing this? I want to touch on the classic and contemporary papers in nursing theory and philosophy with the intention of perhaps at some point explicating a kind of lecture series on nursing theory at the end. But predominantly what I'm doing here is teaching myself about the original thinkers' thoughts. When I did my original undergraduate training in psychology and neuroscience prior to becoming a nurse years ago, what I found is that when I read the original thinkers of some kind of primary psychological theoreticians, I found that I took things away from their work that I was not getting when I read the secondary literature. And by secondary literature, I mean secondhand accounts of the original thinkers' work. There are some really good ones. I read a fantastic secondary account of Jean Piaget, which is helpful because Jean Piaget is difficult to read in his original works anyway. But nonetheless, reading the original Jean Piaget, reading the original Sigmund Freud, it offers you the opportunity to take things away from it that you might not have otherwise. And I think the same thing is important for the original nursing literature in terms of the theoretic literature. So this 1963 paper, this was actually republished in a Canadian Nurse Journal in 1964. Essentially, I think of it like a culmination of Lydia's ideas on the demarcation between nursing as a profession and other disciplines in healthcare. And we do this a lot in trying to demarcate nursing from medicine, for example, in the same way that philosophers of science will try to demarcate what constitutes science versus pseudoscience. And I don't mean to lay this problem out that way as if nursing versus medicine is similar, because it is not, at least not in my mind, and not for the purpose of this videocast, or whatever this is, podcast. What I'd like to do is to tell you about what I find compelling about this paper, but I'd like to start with one of the things that I have trouble with, and it's the very first quote on top here. If you can see it, it says, "Physicians do not have practical doctors. They don't need them. They have nurses." This, at first when I saw this paper, I thought this was a quote that maybe she stated somewhere. It's actually in the paper lower down at another page. This paper is only a few pages long, so this will not be terribly long and arduous, but I do want to talk about some of her ideas. So, physicians do not have practical doctors. I don't know what she means by this exactly. We can infer I don't think she means practical doctorates. Like, they do clearly have a clinical doctorate degree. I don't think she's really talking about the degree program. I think she's talking about performing hands-on skills with real human patients. But there seems to be two bidirectional implications here. The first implication is that doctors do the thinking. They don't need to do the hands-on stuff because they have nurses, right? And nurses do the hands-on stuff. We implement the care. And I think largely this is true, but largely leaves a lot of room for overlap. And the overlap is that the implication of overlap is not implied with this statement. And I want to give her what she is due, by which I mean, this is one line from one paper, and this does not adequately describe exactly what she thinks necessarily or thought. But this is what we have to work with. So I don't exactly know what she means by practical doctors, but I can infer that what she means by they don't need them is they don't need to do the hands-on care because we do it for them. So the first implication is they do the thinking and we do the practice. And although that's largely true, it is not exclusively true. And she does make in this paper a couple statements about this being exclusively the domain of nursing. I don't mean to misread her if that's not what she had meant, but it's the way that it reads to me, at least on occasion, as I peruse this paper. The other thing that it implies is, of course, that doctors don't do things with people or to people. And that is, of course, not true. Now, the more sort of internal medicine-based medical practices, those domains tend to be more thinking, less doing. But there are plenty of medical specialties and subspecialties which focus on practice and which focus on doing things. In fact, there are some medical specialties and subspecialties which do patient care almost entirely without nurses. For example, ophthalmology. Not only are they a physician subspecialty, a medical subspecialty, where they are dealing with real patients and they are doing things to them, including ocular surgery and all sorts of other things, eye exams. They're also educating the patients on eye health and all sorts of different things that fall into their realm. And most ophthalmologic outpatient programs or business practices have their own ophthalmic assistants. I forget what their technical certification and title is. It's not a domain that I'm especially familiar with, but I know they exist. They have their own, let's call them, for the sake of this argument, ophthalmic assistants. So they're not nurses. They're not trained in nursing necessarily. Are there nurses who might exist in that domain? Possibly, probably. I actually have no idea. But I would imagine so, or at least it's conceivably so. So the first point of contention that I have with this paper is that the implication of this first line, although is largely true in certain contexts, really is context dependent. But that also, because it's elevated to the topmost point of this paper, implies that this is the demarcating phenomena for nursing what is it. I mean, the title, Nursing What Is It, is right there. And then this line falls right under the title, as if this is the important takeaway for the reader. Now, I don't think this is the important takeaway for the reader. I think there are lots of important takeaways from this paper, that self-management is an important component of nursing care, and the education and edification of the patient and the expanding, I almost said expanding consciousness. I'm going to slap myself for that, but something about the patient's experience of himself or herself expanding as the nurse works with that person. I don't think those are exclusive to nursing either, but I think that there are critical takeaways from her ideas later on in the paper, which we can talk about. But because the journal elevates this line, I think what they want is for this to be your takeaway. Nurses are the practical implementers of patient care. Now, I will say, in my own conception of what constitutes nursing and the demarcating factors of nursing versus medicine, implementing healthcare with real human patients at the bedside is more often the domain of nursing, and the implementation problem has its own science and its own expertise that nursing has tended to fill predominantly. So the distinction between that idea and this one is this is a binary idea. Physicians don't practice or hands-on, let's say, nurses do. That is a binary. Those are two discrete categorical boxes where I don't believe that adequately captures reality. There is overlap. I exemplified one possible way that there is overlap. That overlap in ophthalmic care, ophthalmologic care, is almost exclusively the domain of medicine. And it's not as if nurses don't care about our patients' eyes. Of course we do. But the most I do with eyes in the ICU, for example, is like put drops in and make sure that their pupillary responses are appropriate. And that's just one context. And so anyway, the point I'm making here is that there is a difference, a distinction at the mean and the extremes of these two overlapping distributions, but they are precisely that, two continuous overlapping distributions where the level of practical applicability in the practice of nursing versus the practice of medicine may differ slightly, but it also depends on context. It depends on the professional. So I know I started off with a point of contention, but I want to talk a little bit about I guess in my screen, this is the left-hand side of my screen. I don't know what it will be for you, but there's a little diagram, a little figure here, which in most research journals would be like figure 1. It's the first figure that appears on the screen. It looks like a little sideways triangle here with a couple lines in it like a ladder. And it says the word simple and complex, if you can see this, if you're watching on YouTube. If you're listening to the podcast, I'll describe it a little bit for you. Essentially, it's like a ladder laying on its side with the leftward side is more pointed. And it expands as you move to the right. And the word simple is toward the point, and the word complex is toward the right side, which is, I guess, the base or whatever it is, the expanding rightward aspect of this figure. And what she describes in this paper and what I take away from this figure is that there are oftentimes simplistically, at least seemingly simplistic, tasks or activities that nurses perform at the bedside with patients that are in some sense superficial and yet are nuanced and can be complex, particularly complex depending on how far down you want to go, and are predicated on theoretically derived conceptions that are not often obvious at the interface of practice. At the risk of that all being a little bit too convoluted, what I'm really saying here, and what I think she did quite well, is point out that nursing is associated with these simplistic, superficial tasks, but that's not all it is. That nursing is based on something deeper and more complex and more nuanced. For those of you who are listening who are nurses, we all know this implicitly, even if it's understated or unstated. And for the physicians and attendings listening, and I know there are a couple, you tend to know this, especially if you work in the ED or the ICU or directly with the nursing staff on a day-to-day basis. This is something that you see. Especially, this is just the example that comes to mind, but in the case of a dying patient, where you're working in a highly complex environment with the patient's family who are actively grieving the soon-to-be loss of their loved one, and yet care still needs to be accomplished, tasks still need to be done that are seemingly superficially simple, but are actually deep and complex in subtle and nuanced ways. So I think this is one of those things we take for granted. I mentioned Freud earlier. The idea that Freud put forward that is often taken for granted is the idea that we have an unconscious mind that is deep and expansive and often comes out in ways that we don't anticipate or understand on the surface. And this not readily apparent line of thinking and cognition that we have that he termed the unconscious. This is obviously true today in modern psychological science, and yet it is taken fully for granted by most students of psychology and most people in general as being like a kind of a duh moment. But it's not a duh moment in the sense that it was his original idea. I would not make the claim necessarily that it was Lydia's idea initially or originally, that nursing is complex but often seems simple, and it's based on these kind of deeper ideas. I think other nursing theorists and thinkers had kind of described this well before her. But I think the thing that she did that was more novel here in the early 1960s is point out explicitly the line of thinking that other people view nursing tasks as being simple, and we know that they're predicated on something deeper and more complex. There are lots of things that I would like to say about this paper, but there are a couple of core claims, kind of moving on from this diagram here, that I would like to talk a little bit about. And one of the things that let me actually start quickly by saying that there's a point at which she talks in this paper about nursing as a vocation versus nursing as a profession. This paper preceded or predated the Donaldson and Crawley famous paper. I think it was 1967 that was published. I could be wrong about that. It might have been the early 1970s, but this paper by Lydia preceded that Donaldson and Crawley paper, which essentially describes how nursing is an independent discipline and what it means that it's a discipline. And I don't mean to conflate discipline and profession per se, because I think that they're slightly distinct concepts. But what I don't understand from this paper, this is a minor point of contention, is what exactly she sees as the differentiation between nursing as a vocation and nursing as a profession. I can only imagine that she means that vocation is sort of like a stand-in word for technician, and that technical skills are not all that this is, that the word profession connotes something deeper and more complex, and sort of speaks back to her point about the nuanced complexities of the predicates of nursing. But I think I'm only putting that out there for those of you who might read this and perhaps come up with something slightly different about that. Now, the core of this paper and the thing everybody takes away from this paper is actually also not the thing that I agree with in terms of Lydia's conception of what differentiates nursing from other disciplines. So there's I don't know that she calls it anything in particular, but there are 3 overriding circles in a diagram that she describes, which I'll show you on the next page here, which talk about the underlying philosophies of care, the supporting sciences that underlie the care, and sort of the philosophical dynamics involved, and how nursing sort of sits in the center of these things and effectively transcends existing in just one of these buckets, as I think she would argue that other professions tend to do. So let's look at this diagram for a second here. So I wonder if I can make this a little smaller. Oh, yes. So on the screen here, you can see 3 overlapping circles. I don't know if you can actually see my cursor, but if you can, there's this space in the very center that I believe that, based on this idea, Lydia would argue that we fall into as nurses. There's 3 overlapping circles, 3 dimensions, and one of them is the core, another is the care, and the third is the cure. The core, the care, and the cure is the most famous element of this paper. Sometimes I think or wonder if this type of thing happens because people find these sort of simplistic tropes easy to remember, and And it's an elegant idea, if true, such that this idea of the three dimensions, the core, the care, and the cure of nursing is like easy enough to remember. But essentially, she explicates the idea of using the social sciences and an understanding, kind of a therapeutic understanding of the self that is involved in patient care with human beings as the core aspect of nursing. The care aspect of nursing is really predicated on an understanding of the natural sciences and this, as she says, intimate bodily care aspects of nursing. This is, how are they supposed to function? How is their body supposed to work? And then, of course, the cure, as she describes it, is about the pathology, the therapeutic sciences. This is essentially, and I think she writes it in this paper as, this is where nursing overlaps with medicine, or this is the shared domain of medicine, I think is more how she describes it anyway. And I think that's an elegant way to depict this, because there is a shared element of nursing care that overlaps with medicine. And I think where some thinkers would suggest that that is medicine, and you could make that argument, I tend to think that, I interviewed somebody on my podcast last year who I have great respect for. Her name is Anne Sales. Dr. Anne Sales is an implementation scientist and nurse who has a host of really interesting research interests, and she believes that nursing science doesn't exist, but neither does medical science. It's not nursing and medical science. It's that there is science which underlies the practice of nursing and medicine. I don't want to put words in her mouth, so this is where I would, suggest my own kind of tangent on what she has posited on my podcast, which is that perhaps in that line of thinking, nursing and medicine are more like engineering human outcomes, which I've talked about on the podcast myself. I think, and we won't talk about how engineering health outcomes in nursing could be different from medicine per se. On this episode, we can save that for a different episode. But in the sense that we both share this cure component, this cure dimension of these three overlapping circles, she might suggest, or at least possibly agree with me, that it's not that this is medicine. It's that medicine uses the sciences from pathology, which is a biological science. There are pathologists who are not physicians, and pathology is the understanding of disease at the cellular and tissue level or organismal level that is derived from physiological researchers who study disease, and disease is biology. So I don't need to belabor this point, because you could argue that it's semantics and it doesn't matter, that medicine is the practical application of the science of pathology. Sure. The point I'm really making here is that I think it's perfectly acceptable to say that we share this dimension of care with physicians. And I think there's utility in constructing this circle the way that she has. The problem that I take away from this, and I think other people should at least recognize, even if they disagree with me, is that there is an implication that if you looked only at the disease circle, that's where physicians would lie, but not in the side of, not in the dimension of the person or the body. There's also an implication that there are people who exist in, let's say, the core, the person space, that don't occupy any of the other spaces, and you could make that same argument at each of these. I just think ultimately this type of oversimplification, this in a way, and this partly also could be why people conceive of Lydia's work as being a meta theory, because this figure that we're looking at here, these three overlapping circles, we would consider this diagram is kind of like a model. I would say it's not a particularly well formulated social scientific model per se, but nonetheless, you could argue that this is a kind of theoretical model Whether she intended it to be that or not, I can't say. And the issue that I have with this is it's not unsophisticated. It's just overly simplistic. This does not capture sufficient nuance. And even though it implies some overlap in different dimensions, I just think that it is too simplistic to capture the true nature of reality. And, the reality of it is that models are overly simplistic representations of what constitutes true reality. But there is such a thing as an overly specified model with too much model fit and an unsatisfactorily nuanced model that is overly simplistic. Let's continue. There is one component of this paper where Lydia talks about the interpersonal nature of nursing. And this overlaps with Hildegard Peplau's conceptions of interpersonal nursing, which I very much like. But again, I think that they're not really capturing the nuance because it implies that physicians do not practice interpersonally. Now, it could depend on how they're thinking about the term interpersonal. What does it mean exactly for it to be interpersonal? I would still take issue with that depending on the level of closeness with bedside patient care she means. I would imagine that she means, specifically that the closer you are to bedside patient care with real human beings, laying your hands on an actual human, that's more of the interpersonal nature. But she doesn't state this explicitly per se. There's a lot of kind of high level verbiage that's difficult to disentangle without being able to ask her exactly what she means here. But one of the things that I liked is that she did describe how it is difficult to understand what people mean when they say interpersonal, and kind of what I gathered from what she expounds in this paper is that part of the nurse's job is to help the patient also to develop a deeper understanding of themselves and to essentially utilize that unveiled self-knowledge to help themselves further with their care. I think that's brilliant. And I think it's brilliant because a big part of what I think nurses do, I would not say is a demarcating factor per se of nursing versus any other health profession. But what I would argue is that nurses do this well and they do this consistently, whether or not it's explicated in their practice. But I think that the self-care of disease model, we call it self-management in nursing model, was really well described in this paper. And I like the way that she described it because it sort of builds itself out from her discussion of what interpersonal care means, or what an interpersonal relationship means as it develops. The one thing that came out of that I disagree with, but that I also thought was interesting, and I think you should consider for yourself whether you agree with this or not. And I won't tell you why I disagree with it yet because I don't think that's relevant, and I also don't want to bias you too much against her work here. She makes the claim that, and I'll actually read the statement to you. She says, this exclusive nurturing aspect of nursing involves the laying on of hands with comfort of the patient as the main interest, and if understood as the main result. It's interesting that she says if understood, because I don't exactly know what she means by comfort. I don't know if she means satisfactory palliation and pain management. I don't know, I don't know exactly if she means like patient's personal satisfaction of care or something else. There are lots of different constructs that could represent, which is the thing that I teeter on, because if she only means comfort, like physical comfort, lack of pain, something like that, then I actually don't agree with this at all. But the way in which this leaves room for me to agree with her is in the sense that because I don't know what she means by comfort, it could be an umbrella. It could be an umbrella term that encompasses a number of different constructs that are important to nurses. And perhaps if it's an umbrella term that encompasses all of the different constructs that are important to us in terms of, that patient's satisfaction with care and physical comfort and psychological comfort, et cetera, perhaps that's a decent description of what we care about in terms of our outcomes. I do think, again, there's still an implication that there's a dichotomy here, that medicine only cares about the disease amelioration and doesn't so much care about the patient's comfort at all. But physicians are people, and physicians care about people. And whether or not they care about people as much, or they care about the same exact things about people that we care about, that's sort of not the point. I think there are these blanket dichotomous statements that are just not accurate about, what we care about versus what physicians care about, that come across as discrete or dichotomous that just are not. It's not true. But I think there are ways of making arguments like this that are relevant. But what I'd like you to think about, getting back to the point here, is that she does make this claim, as I read from this last line of the care, is that this nurturing aspect of nursing is exclusive to nursing, and that that comfort is the primary outcome of this aspect of nursing, which is nursing care. So therefore, nursing care is primarily and exclusively oriented toward comfort as a main interest and outcome. I don't know that I can get behind that exactly. Not because I don't agree with it in some broad-based sense, but I don't agree with it specifically depending on how she defines comfort, which she doesn't define here. We could talk about the cure, but the cure, sort of the overlap with medicine, shared. This is how she writes it. The second aspect of the nursing process is shared with the medical profession. I think nursing and medicine share this with the biology of perturbed or altered physiologic states, which is a biological science. And we just happen to apply that science in different and overlapping ways. But we can talk about that in a different podcast. There's this beautiful segment, and we're almost done. So I hope that you stuck this out a little bit, but there's a beautiful segment in this paper called The Core. And I want to read this to you because I think it is excellent. There are things in it that I don't necessarily agree with implicitly, but that's neither here nor there. So let me read this to you. Quote, "The care for the person of the patient we must draw as freely from the social sciences." Let me start over. Sorry. "To care for the person of the patient, we must draw as freely from the social sciences as we have in the past from the natural and biological ones. To view the patient as a body, a disease entity, has long been decried. To view the patient as a person with a diseased self as well takes into account the too often lip-serviced slogan, 'Patients are people.' What does this operationally mean? What does it mean that we nurse the whole person? This phrase is used ad nauseum and in operation usually comes out as though spelled the whole person, H-O-L-E. I have no idea what she means by that. It is impossible to nurse any more of a person than that person allows us to see. That, I think, is crucial. I think, though, the implication here, I should unquote, I'm talking for myself now, the implication of we're only able to nurse the whole of the person they allow us to see is brilliant, because it implies, again, the deep, deep kind of unconscious, in some ways, nature of humanity, and how people often, and whether they're patients or not, are often psychologically veiled behind several different layers of different types of walls and safety mechanisms. that there actually are some important considerations for health disparities there, which we can talk about in a different episode of the podcast on disparities. But for the sake of this, I just think the way she describes that is epic. I'll continue. Rereading that last line, quote, "It is impossible to nurse any more of the person than that person allows us to see. If we permit him to utilize our freely offered closeness, he will not only let us see more of him, but he will allow himself to be more of him." Unquote. Also beautiful and brilliant, because what she's implying here, and I love this, is that if the patient is amenable to our care and closeness, he'll open up more. So we'll be able to see more of the patient's challenges, let's say, and the patient's strengths. Part of what's implied here is that if other professions are not doing this, are not engaged in this closeness and are not proximal to this level of care, they won't be able to see some of the things we are able to see in nursing. I think that is beautiful. But then she goes on further to say that as you do this with somebody, as you embrace that closeness and proximity, if you are doing that in your nursing care, although I don't think it necessitates it is nursing care per se, because social workers can do this sometimes, psychologists can do this sometimes, friends can do this sometimes. But I do think there is something unique about the fact that she states that as he allows himself to do this, he also learns, in this case they learn about themselves. And it's that learning about self that also opens up further opportunities for self-care. I'll continue. Quote, "He will not only let us see more of him, but he will allow himself to see more of him, so that he may, with excellent professional nursing, emerge as a, quote, whole person, in which case he won't be ill and, according to some schools of thought, will stay well. In addition, in the process of exploring with such a nurse who he is, where he wants to go, and will he take or refuse to get help in getting there, the patient will make rapid progress toward recovery and rehabilitation. For the nurse to use self-therapeutically, she must have help through nursing education to learn who she is so that her own concerns will not interfere with the patient's exploration of his concerns. Besides this, her learning experiences through the media of the social sciences must facilitate the development of interpersonal skills that permit the patient to be, and in being, to participate in facing, solving, and preventing health problems." Unquote. I'm going to just be a little bit of a stickler. This idea of to be and in being is precisely the kind of thing that stems from Martin Heidegger's work. And although there are elements of Heidegger's work that I think are crucial to contend with, I think much of people's interpretations of Heidegger's work are nonsensical. And I think the nursing profession's use and misuse of Heidegger's work is nonsensical. I also think it's important, and I don't say this lightly, to recognize that Martin Heidegger was an active Nazi, joined the Nazi party. And so I am not somebody that believes that you cannot totally disentangle an individual from some of their horrible ideas, and vice versa, or a horrible individual from some of their good ideas. I think you can do that, but I think that this liberal over-application of Heideggerian thought in nursing is annoying, frankly. And I think people should have done a better job of, and maybe I'm not being charitable enough, of scrutinizing his ideas. But because it was suitable for their narrative at the time in the 60s and 70s, it just worked beautifully for them to leverage some of his horrible ideas and some of his really good ideas in a way to kind of self-servingly expand the theoretic ideas in nursing. But we can talk about that at a different time. Anyway, the point of this last piece I want to point out here for her, and I'll end on a very positive note here, I think, is that this article came out, as I mentioned, the presentation was delivered in 1963 in Toronto, and the paper was republished in the Canadian Nurse, as you see here on the bottom right of the screen, in 1964. This was, again, it predated and preceded the work on motivational interviewing, which is, I mean, I guess there was some work from the original work from Carl Rogers in clinical psychology and counseling world focused on the ability of a clinician to unconditionally support and care for a person where they are at. So some of this could have been floating around at this time. I don't know what Lydia's primary clinical orientation was, if she was a psych nurse or not. I will say most theoreticians in nursing were psychiatric nurses, and so it could also be that she was familiar with Carl Rogers' work in some regard. But the idea of, leveraging this sort of client-centered therapy from Carl Rogers' approaches and unconditional positive regard that led to motivational interviewing really did not occur for some number of years after this paper came out. So even if Lydia was familiar with Carl Rogers' work, the fact that she was seeing this type of evolution in her own practice and potentially in other nurses' practice and from nursing in general, she was deriving this idea that you have to meet people where they're at. And this is one of the ways I think that nursing tends to do a far better job at its most advanced levels than medicine at almost any level. Although that sounds like a blanket statement, I understand that this is not widely applicable on the whole as an overgeneralization. But on average, it seems to be the case that nurses are more likely to meet patients where they're at, meet families and decision-making where they're at, and to try to help them understand themselves better. But the implication that she's making here is that you don't interfere with the patient's exploration of his or her concerns. You let them explore themselves and meet them where they're at. And what she's said here, and I'll read it again, quote, "For the nurse to use self-therapeutically, she must have help through nursing education to learn who she is, or he, so that their own concerns will not interfere with the patient's exploration of his own self-concerns," unquote. So that is fascinating, because in the same way that social workers and clinicians in the mental health space have had to learn, I think that my friend Robin, who is a social worker for 17 years a brilliant social worker before she became a nurse, shout out to Robin. I think she has said it best when she says, clinician, heal thyself is sort of one of the things you learn in your master's program in social work and clinical mental health counseling and the like. One of my best friends in the entire world, her name is Audrey. Audrey is a phenomenal marital and family therapist, has said the same thing to me, that she learned about herself in her master's program, and that helps her to not, in the clinical world, the term is countertransference, to not participate in the transference process and to elicit countertransference from herself, from her own sort of bullshit. That idea is brought up in this 1963 paper by a nurse called Lydia Hall, and I think that is just excellent. And this is where I'd like to end it. So what's the summary of this paper? I think, if I were to commit my own binary or dichotomous fallacy here and categorize this as an excellent or not good nursing theory paper, I would say this is an excellent nursing theory paper, because she is clearly deep and thoughtful. I don't really agree with that dichotomization in general, so you can ignore that. That's kind of a joke, but I think this is an important paper. Do I think that this explicates a profound meta theory demarcating nursing from other disciplines like medicine? No. Do I agree with the underlying model conceptualized with this diagram of 3 overlapping circles, the core, the care, and the cure, and that distinguishes nursing from other disciplines because we sit at the center of those overlapping circles? Absolutely not. What are the takeaways that I think is super important about this paper? I think there are two things that I take away from this paper as being extraordinarily important. The first thing I take away from this paper is that in order to help somebody, you have to care for them enough such that they will open themselves up to you. And this ties into the second piece, which is that as they open up to you and you meet them where they're at without undue influence from your own nonsense, they learn about themselves more and more. And you're able to even further help them with that new self-knowledge that has developed to attain a new state for themselves, whatever that state happens to be, and to evolve with them so that you can effectively care for them by meeting the patient's needs for self-management. None of that is, Lydia uses the word exclusive to nursing a lot in her article. I think it's mentioned at least 3 or 4 times. While I think she's a deep thinker, and this was a phenomenal paper in lots of respects, I don't agree with the word exclusive, and I don't agree with a lot of the dichotomization that occurred in this paper, as in demarcating nursing from medicine in a dichotomous way. I will say, however, in wrapping up here, that there is a sense in which Lydia's ideas can be true, or can hold as true, if we look at them as being points on a continuous distribution where there are 2 distributions, one for physicians, one for nurses, and they overlap in these different domains. Let's say for caring. If you think about there being a distribution of care and a distribution of nurses and a distribution of physicians, and the concept of caring, and then the construct of caring, and then the practical concept of having cared for a patient, there's going to be some physicians way out here at the end of their distribution, some way out here, and the same thing with nurses, and they're going to overlap to some degree. It's in the average, at the mean, or at the extremes, where there are important differences between the 2 professions. I think that's a perfectly acceptable way to conceptualize the demarcation problem, and even the idea of a demarcation problem implies discrete categories, which I just don't agree with. I just don't think that makes sense. If you imagine that nursing and medicine both stem from different applications in an engineering type of sense of basic biological and social sciences that just have different foci, it's that the differences are in the mean and the extremes of the foci. And I think that what Lydia does here really excellently is describe the differences in how we elicit those foci with, not from, patients.